Right, good morning, everybody, and welcome to this event. This is the WHO Religions for Peace Global Conference on Strengthening National Responses to Health Emergencies. We really are delighted to have you with us here today. My name is Sarah Hess, and I work in the Health Emergencies Program at WHO in Geneva. And I'm very pleased to introduce my director, Dr. Sylvie Briand, who is going to give some opening remarks for this conference. Sylvie, please, over to you.
Many thanks, Sarah, and good morning, good afternoon, or good evening, everyone. Welcome to this first conference hosted jointly by WHO and Religion for Peace on strengthening national response to health emergencies. WHO, religious leader, faith-based organization, faith community, and national governments. Thanks. I express my profound thanks to Prof. Asa Karam and her team at Religion for Peace, as well as the many faith partners, academics, WHO colleagues, and others who have worked with us through the interfaith community of practice and working groups to develop and shape this very important conference. COVID-19 is still a global pandemic, affecting every country and all people, and demands a whole of society global response. We have all a critical and complementary role to play. And this pandemic has highlighted the critical roles of people who have been little noticed in the past: nurses, for example, palliative care specialists, and chaplains, who have provided invisible but important spiritual care to patients and their family. This conference will offer space to some of these people on the front lines to share their stories. The pandemic is not over yet. There will be long-term consequences of this event in every part of society. We know you are committed to working with community for the long haul, and WHO is also committed to working with faith actors in this health emergency and beyond. We need to work together, not only to make sure that all the public health measures are sustained everywhere to reduce the spread of the virus, but also to rebuild global solidarity, the principles of caring for those most vulnerable, or sharing of equity, of justice, and dignity. Whilst public health value and scientific evidence are critical to the response, so are faith and religious values. We are moving forward with that coalition of the willing, of partners who are prepared to listen and learn from one another and to shape new and different ways of working together. Religious and faith community play key roles in society and in pandemic response. Religious leaders, your faith community, and infrastructure are already playing an essential role in this pandemic response, in vaccine preparedness as well, in vaccine delivery, and advocacy also for equity. And inequity, in my opinion, is the cancer of society today, and we need you more than ever to overcome this. We recognize that religious and faith tradition manage significant and sophisticated health and social service infrastructures in many countries, including schools, universities, hospitals, clinics, feeding programs, and also in disaster preparedness work. All of these are currently being used in many countries in support of national COVID-19 response. Part of this important work is to provide pastoral, spiritual, and mental health care to community, palliative care, care for the dying, care in bereavement, food for the hungry, shelter for the homeless, and providing community and accompaniment to those struggling to cope or lonely. The tsunami of mental health crisis created by the pandemic is one of the faith community are well placed to partner with mental health professionals to address. I'm pleased to see strong collaboration developing in this area with WHO's mental health departments. I would like to take this opportunity to express, on behalf of WHO, my deep respect for the effort being taken by faith actors globally in responding to this COVID-19 pandemic. And thank you very much. We are so honored to be walking part of this journey with you. I wish you a very fruitful conference. Thank you.
Thank you very much, Sylvie, for being with us here today. A couple of quick housekeeping comments before I hand to our co-host Deepika. We are recording this webinar. It will be live streamed on YouTube, and we will be able to direct you there to these recordings after the event. If there are slides shared, we will also be able to share those with you after the event. And I really just look forward to you joining us. We have a number of sessions happening between now and December. I think we will post links to the webpage where you can see an overview of all these sessions. And thank you once again for joining us. And Deepika, over to you. It's really been an honor and a privilege to work with you on this conference. So thank you for the partnership.
Thank you so much, Sarah. Good morning, good afternoon, and good evening to all. As Sarah mentioned, my name is Deepika Singh, and I serve as the Associate Secretary General and the Director of Programs at Religions of Peace. Before we start, please allow me to request that we observe a moment of silence to remember all those who lost their lives due to COVID-19. So a moment of silence, please. Thank you so much. First of all, on behalf of Religions of Peace, I am so pleased to join WHO in welcoming you to this first session of the Global Conference on Strengthening National Responses to Health Emergencies. For over 5 decades, Religions of Peace has been working through multi-religious, multi-stakeholder collaboration to address common concerns, including responding to public health crises, such as the one we're facing now. So when the pandemic struck, we established the Multi-Religious Humanitarian Fund to support multi-religious responses to humanitarian crises such as this pandemic. The fund has enabled and supported, among many other, to provide pastoral care and other spiritual services, which we know is most critical at a time when COVID-19 has taken such a tremendous toll. Faith leaders, as we know, are at the forefront of providing spiritual care. They are great sources of solace and resilience. They enable people to cope with adversity and pain in their journey to heal and recover, as well as to come to terms with very traumatic events. However, the pandemic has challenged them and other spiritual care providers to deepen the engagement as well as adapt the ways they provide their chaplaincy services. So we're most fortunate that today we have great experts who will be highlighting some examples of chaplaincy from different faith traditions from different parts of the world. There's much to share and learn from each and every one. So we thank you all for joining us as we look forward to together exploring ways to strengthen our collaboration for the spiritual well-being of all. So thank you so much. And I hand it over to our moderator, Fabian. Fabian, over to you.
Yeah, thank you very much, Deepika. I'm Fabian Winiger. I'm at the Professorship of Spiritual Care here at the University of Zurich. And a very warm welcome from myself as well. It's really a pleasure to moderate this panel today. To the best of my knowledge, this is the first time that WHO hosts or co-hosts an event on professional healthcare chaplaincy or on spiritual care. And so we put a lot of effort into organizing this conference, and I'm really very happy to be here with you all today. And just before we begin, a quick heads up that we have 7 minutes per speaker. So please stick to the time limit. And with that, I would like to welcome and introduce our first speaker for today, and that is Austyn Snowden. So Austyn is the professor in mental health at Edinburgh Napier University in the UK. He's also the lead researcher at the European Research Institute of Chaplains in Healthcare, short ERICH. And Austyn will begin our session by giving us an insight into the results of a major survey on the role played by healthcare chaplains in hospital settings during this COVID-19 pandemic. So Austyn, a very warm welcome to you, and the floor is yours.
Thank you very much, Fabian, and welcome everyone. I shall share my screen and hopefully you'll be able to see my presentation there. So thanks for the introduction, Fabian, and it's a real pleasure to give the first presentation of this really quite unique conference. Because mine is the first presentation, it's fallen to me to do some basic definitions and scene setting, as well as giving you some insight into the survey that we did. So I'm going to start with one or two definitions of terms, spiritual care and healthcare chaplain in particular. And then I'll go on to show you where I think the position of the chaplain is within the interdisciplinary team based on the evidence. And then I'll follow that up with some quick results from the survey. And after that, I'll hand on to the next speaker. And all that will be done in 7 minutes. So here are the definitions. And it's very important to say that there is no consensus about the term spirituality. There will be as many definitions of spirituality as there are people who've ever thought about it. But the World Health Organization and the European Association of Palliative Care use the definition on the left. Spirituality is the dynamic dimension of human life that relates to the way persons, individual and community, experience, express and/or seek meaning, purpose and transcendence, and the way they connect to the moment, to self, to others, to nature, to the significant and/or the sacred. Now, if you look at any definition of spirituality, there's always those elements of meaning, purpose, transcendence, and connection. They're just about common to all. And the definition of the healthcare chaplain on the right, I've used the UK Board of Healthcare Chaplains definition, but again, this is contentious. In Australia, for example, they don't use the term chaplain at all, but pastoral care worker. So, but for the purposes of this particular presentation, I'm describing a healthcare chaplain as someone who is appointed and recognized as part of the specialist spiritual care team within a healthcare setting. His or her job is to seek out and respond to those who are expressing spiritual and/or religious need. And I think that definition fits nicely with the place of the chaplain within an interdisciplinary healthcare team. This is a replica of Sinclair and Chochinov's model of where the chaplain sits within an interdisciplinary team. So it's an extension of the biopsychosocial model to include spirituality. So you've got the bio in red, physical, the psychological in green there, and the social in yellow. And those have their representative healthcare specialists. Excuse me. So the psychologist, the social worker, and the physician cover those elements of the person. But of course, the person has a spiritual side as well. And so the chaplain is the specialist in spiritual care, sitting alongside these other specialists to deal with whatever issue that the patient may present with. And that depends on whether they've got a physical problem, psychological problem, social or spiritual. The idea being that they see the relevant specialist. All healthcare people have a sort of generic quality skill to deal with all of these aspects, but we require specialists in each, and chaplain is the specialist in spiritual care. So on to the survey. I can't tell you all the results, and so I've left the results in a special edition of Pastoral Care and Counselling, and the reference to that is at the end of this presentation. So I'm quickly going to say that we sent the survey out through our colleagues in Australia, Spiritual Care Australia, the Association of Professional Chaplains in the USA, and it was hosted by ERICH. And we sent it out to as many chaplains as we could worthwhile to find out worldwide, to find out what happened to them during the pandemic, whether they were clear on what their role was, and whether that role changed. And just to be clear, we sent this out within the first few months of the pandemic. So these results are from June or July 2020. And we had 1,660 responses in total, with a nice balance between the States and Europe, and about 300 from Australia, with the remainder from elsewhere across the world. The key point, and I don't think this was different for many other healthcare professionals, but that chaplains weren't clear on what their role was initially in the pandemic. And so that leads on to the next finding, that the majority of them felt that they could have been better deployed in the first instances. And this, when looking to explain that, seemed to be a function of the attitudes of their managers. In other words, some chaplains were very deeply involved in planning, strategy, management. For example, in Scotland, 15 chaplains were involved in a new hospital that was prepared for any overflow that was required. Whereas others in other countries and in other conditions were excluded, misunderstood altogether. And so once they became a bit more settled, the majority of chaplains, they developed their roles really quite creatively and supported patients, families and staff in ways that we're going to hear about in the following presentations and further on. And a lot helped the staff support what was a terrible time for them. But all in all, to conclude, and this really is a snapshot fly through the survey, the general sense was that they could have done with stronger leadership, that chaplain needed a greater place at the table to be able to influence healthcare, not just during the pandemic, but post-pandemic as well. And I think that's one of the take-home messages, and also why this conference is happening. So I'm going to stop speaking now. I'll hand you back to Fabian, and just to say that you're very welcome to get in touch with me through those contact details there. And the Sinclair and Chochinov paper is referenced there. And if you're interested in the survey results in depth, or you'd like to ask any questions in the conversation we're about to have, please let me know, or have a look at follow that URL to the special edition.
Great, thank you very much. Sorry, apologies, Austyn, we have to stick to the time, otherwise we're gonna run into the time of the other speakers. So thank you so much for this wonderful introduction, which has, I think, clarified this topic for a start. So our next speaker is Wendy Cadge. So Wendy is the Barbara Mandel Professor of Humanistic Social Sciences, and also Professor of Sociology at Brandeis University in Massachusetts. And Wendy is also the founder and director of the Chaplaincy Innovation Lab. And today she will talk to us a bit more about just who chaplains are, what they do, what their effects are on those they serve, and how we can think about them in light of the broader changes in religious demographics, and most recently, of course, in light of this COVID-19 pandemic. So Wendy, it's a pleasure to have you too, and please begin.
Thank you, Fabian. I'm thrilled to be with all of you. A very early morning to you here from Boston, Massachusetts. I'm going to share my screen as well with a few slides. Okay. So to follow on from Austyn, as he has said, it's really not clear who or what a chaplain is. If you go to the Oxford English Dictionary, you get quite an old definition. This is what that definition says. We know, first of all, that both men and women are chaplains. We here in the States at the Chaplaincy Innovation Lab tend to think about chaplains as religious professionals who work outside of congregations, usually for other kinds of public institutions like the military, prisons, healthcare organizations, colleges, and universities. Their particular training and preparation varies depending on the setting in which they work. And where and who is required to have chaplains also varies. So in the States, chaplains, who are increasingly called spiritual care providers, to recognize both the range of their backgrounds and the range of those that they serve. In the States, these individuals are required to, in the military, in federal prisons, and in the Veterans Administration that serves people who are veterans of the military service and current military folks, but they're actually not required in other settings. So one of the big questions that we're asking and trying to understand is how and where chaplains are deployed around the world. We did a survey before the pandemic in 2019 in the States, the first time that anyone had asked what fraction of the American public has had contact with a chaplain. We found that it was about 21% of people said they had had contact with a chaplain in the last 2 years, and almost half, just over half of them, forgive me, had had that contact in a healthcare setting. We will be doing another survey in February of 2022 with Gallup to try to learn much more information about this, but this is our initial sense. Increasingly, I believe, in the United States at least, where fewer and fewer people are affiliated with religious organizations or belong to them, that if people have contact with someone who has religious or professionally religious training, they're not going to meet a local clergy person, not a rabbi or a priest or a minister. They're likely to meet a chaplain increasingly in a hospital emergency room, through the Red Cross, on a college university campus, or with the military. Chaplains were certainly centrally involved in the pandemic, and in the States, they were all over the news. First in New York, and then as the pandemic spread throughout the United States, there were many, many articles about chaplains in high-profile publications. This one here in the New York Times was one of the first, describing chaplains as the women and men who run towards the dying. And many people don't think that chaplains also work in port contexts, on container ships and tankers, as people were trapped on those and were not able to disembark due to the pandemic. Chaplains in port contexts, as well as healthcare chaplaincy contexts and many others, they shifted their roles and did new and different things, working more with staff than with families who often were not present, being a liaison between patients and staff and families because visitors were not possible, et cetera. We got a lot of calls from the media during the pandemic. And one of the things I said over and over again is that the media attention to the work of chaplains and spiritual care is new, but the work itself is not new. It's very old. So some images here of some chaplains in Boston that have done the work historically. The Boston Fire Department has had chaplains since 1906, mostly local clergy who do this in their, quote, free time. The middle image here is Robert Bob Thurman, who was one of the early chaplains at Boston University. And the picture on the right is a historical picture that actually hangs in the chapel at what is today Beth Israel Deaconess Medical Center here in Boston. Part of that hospital was founded by the deaconesses, and this is the chapel and some nurses there many, many years ago. So the attention in the media is new, the work is very old. What do healthcare chaplains look like today? Well, some examples. There are many more examples on the website of the Chaplaincy Innovation Lab. In general, in the States, healthcare chaplains are board certified, which means that they have a master's degree in theology, religious studies, something equivalent. They've done 400 hours of clinical training that in the States we call clinical pastoral education. They belong to a professional organization and are supported by their own religious organization. So chaplains work in healthcare in hospitals and retirement homes and nursing facilities. And as I said earlier, they were certainly called to respond in many new and different ways in the midst of the pandemic. We were thankful through the lab to be able to receive some funds from the Henry Luce Foundation that we use to offer support and resilience groups for chaplains, caring for the caregiver as the pandemic continued, and also to re-grant to chaplains who were doing frontline work. So these grants went to chaplains who were working with administrators in their institutions to try to care for caregivers, nurses, environmental services staff, physicians, and others. A full list of the grantees is on the website that we have, and we think that these funds were able to make a really big and important difference. Increasingly, when people talk about partnering with faith communities, they talk about congregations. And part of what we're trying to advocate through the lab is partnering with chaplains in all of the settings where they work, both because they are serving many people who are not connected to congregations, and particularly amongst the pandemic and beyond, they continue to do frontline work. I'm going to pass here. I appreciate your patience. It's very early in Boston. Back to Fabian, and happy to take questions as we move along. Thank you.
Thank you, Wendy. Just a reminder to the audience, everyone tuning in on Zoom, in the right bottom corner, you can hit the Q&A button and ask questions there. So we'll be taking questions as we go along. And in the last part of this session, we'll be have an opportunity to discuss them. So please use that function, and I look forward to discussing your questions with you. So our next speaker will be Rehanah Sadiq. Rehanah has for many years worked as a Muslim chaplain at the Women's Hospital in Birmingham, which is part of the UK's National Health Service. Rehanah also provided spiritual care on the front lines of the COVID-19 pandemic, and will share her experience with us now. So Rehanah, it's an honor to have you with us, and over to you.
Hi, everyone. Thank you so much. It's my honor to be here and a privilege. Thank you very much. Let me get onto my screen as well, and then we'll be ready to try to stick to time. There. So peace, greetings to you all. I've worked as a hospital chaplain for over 20 years in the UK. And I'm going to give you a little glimpse of a bit of the work that I've done in terms of being a Muslim chaplain. For me, I reflect on, has there ever been a time that has been more needed, where spiritual care has been needed in hospitals than in this pandemic? This has been a time where patients have been separated from their families, where they've been alone in the hospital. I have spent more time in the first 5 months of COVID in the UK than I've spent it on the intensive care units than I have done over the 20 years. A lot of my work that I would do with Muslim patients would be about reciting the Quran, giving healing prayers, putting holy water or Zamzam water on the skin of the patient. Sometimes the staff would call me back because they'd say, Rehanah, we've got some delirious patients and we can't do anything to calm them down. Please, will you come back and will you do what you normally do? And that recitation and that calm that comes to them, I would often find that it would work so beautifully that they'd go into a lovely slumber by the time I'd leave them. Some of the work that I was also doing on intensive care was using my normal work phone, putting it on hands-free, and then allowing the family to be part of the prayer as I prayed with the patient. If you can zoom into this later on, if you want a copy of it, this is the newsletter from the hospital of one of the patients and his families and how they'd written about their experience of chaplaincy. But I chose a few of the words of Ahmed, this patient, and it's public, so it's okay to speak of him, when he was speaking not so much about the spiritual and religious things that were so important to him, but how it affected him physically. He said, the words of the chaplain gave me strength and encouragement to pull through this fight, as well as hearing her recite the Quran. And I feel that that's really important. A lot of my work would be with supporting those families who couldn't be there in the hospital. They were devastated. They used to have a phone call from the family liaison officer in the mornings or afternoons where they would get some clinical information, but to have the chaplain call them and to talk to them about sitting with them and being with their loved one. And I would try to look for the best thing that could have happened that day about their loved one to share with them. And I'd use any kind of device that was that we could use remotely to speak to them. And I've chosen a few quotes for you to just look at some of the impact of that spiritual care that was given, the impact that it had. One brother said to me, of a patient said, "When I listen to you talking about my brother, it is as though I am sitting on the bed right next to him." Wow. And another one, a daughter of a patient, she said, "Thank you for praying over my mother today. Tonight I will sleep." And a wife of a patient who actually died, and she lost her husband, "I could not have coped without the chaplaincy support." And that was Sarah. With Sarah, there was we did some end of life rites at the bedside because the funeral services were not available at that time. The washing of the deceased from an Islamic perspective could not be done. So we did what we call tayammum, using a stone and a symbolic way of preparing the deceased. And Sarah did it so beautifully. We even used the bed sheets from the hospital to do a shroud so that everything was done beautifully. And she did this. And you should have seen how she put the perfume and rubbed it on her husband's beard. It was beautiful. And these will become her memories. These were two of the few things that we used that was prepared by Dignity at End of Life from the Midlands Muslim Chaplaincy Supervision Group. There's a podcast here. If you want to click onto these, you'll be able to hear a fuller story of Sarah. She speaks beautifully about her chaplaincy experience. And then lastly, just to be able to say to you that in the Birmingham Women's Hospital where I'm based, we have parents that have lost their baby after only spending a little time with them. And it's been really difficult to be able to meet their needs, but at least we have the washing facilities there. And we do that. And there was one mum and dad, well, there are many, but I'm thinking of one particular one, who would do the last rites with the chaplain's support, who would do every little bit. And I'll always remember how hard it is for them to put the last sheet covering the baby's face at the very end. Bless them, they had the support of the chaplain. And to finish, this is a quote from a colleague of mine who says, "If the hospital provides nothing for a person who has a religious faith, then they're failing that aspect of that person's holistic care." Thank you very much.
Thank you so much, Rehanah, for this very touching insight into your work. We'd now like to turn to the next speaker. With us now is Father John Masotti. Father John is a chameleon chaplain at the Servants of the Sick in Kenya. And he will now speak to us about his experience as a chaplain during this pandemic. So Father John, a very warm welcome to you as well. And please begin.
Thank you, Fabian, and good morning and afternoon or evening, wherever you are. As Fabiana said, my name is Father John, and I'm a chaplain here in Kenya, Nairobi. I've been doing this for the last 26 years, and also I do chaplaincy training. I'm going to share the practical realities and how I and my colleague responded to this reality of COVID-19. COVID-19 came to our side of the world in March 2020. And during this time, we were on session. We were having a clinical pastoral CP program training. And some of our trainee chaplains, they were in their clinical assignment areas. And that afternoon, it was announced by the government that we have COVID in Kenya, and that was really pandemonic because our students, they ran back to the center really not knowing what to do. One of them said, what are we going to do now? What are we going to do now, because we can't continue going to the hospital? Definitely, it was also very confusing to even us as trainers. But as time went by, after 2 or 3 weeks, we were able to get in touch with these trainees, chaplains and other chaplains in the hospitals to be able to ask ourselves, what are we going to do? Because at that time, actually, we didn't know what to do. At the end of that, we felt a kind of support. I myself felt supported by this connection with other chaplains in other areas who were actually a product of our training center, who had been hired by some hospitals. And this gave me a certain calmness in myself that I was able to take lead to ask, what are we going to do next? Together, we kind of set up a WhatsApp group that made us connect so that we began to share. There were a lot of information moving around through social media, but through this WhatsApp group, we decided not to consume this other information from social media, to take only from credible sources, especially from our government and from WHO. And therefore, that helped us to be able to get credible information. And that information actually was very consoling to us on the infection and how we can prevent that infection. And in that way, we were able to regroup and be able to be available to give care to our patients. After a while, actually, the government began to implement the protocols for the guidelines to prevent the spread of COVID. And there was strict no groupings, also no movement. That was really very difficult for us as chaplains and for many people, even the patients. And actually from this part of the world, actually, the enemy, when the enemy has come, we don't go away, we don't run away, we come together. But here we saw COVID as an enemy that we were told to separate. And for this reason, we saw many people defy that directive of not grouping. We saw people meet even at night coming together. And some of them, they wanted to come to some of the chaplains. I myself, I was called by 3 people who wanted actually to come to us so that we can be able to pray together. And for this reason, actually, isolation and movement restriction was really a big pandemic on top of the COVID-19. But however, we were able to be together and be able to be available on call. So our chaplaincy services were not the routine way that we knew how to do. Now we depended on call services. Some of the hospitals could call the chaplains from home so that they could give care to the patients who had requested to be given care, spiritual care. For that reason, we got an opportunity to give care. Many of us, who were in this social media WhatsApp, we were able to discuss and share and identified some of the particular needs our patients had. Particularly, we identified that our patient needed to hear the word from us. In terms of reading the sacred scriptures from the Bible, also prayers, to hear prayers said for them. Also songs, to hear rhythms of songs, and also being blessed. Here I'm going to share particularly the real experience of what I got myself. One day when I was in this particular hospital where I work, and I had finished lunchtime service, and there were a group of people who had come to see their own, who was COVID positive, but they couldn't access this patient because they were a group and he was in isolation. And they were really agitated. And then we came together and I had a talk with them. And they decided to sing outside the ward and record that. And I was able to take this recording to this colleague of theirs, and they listened to this song. And they said, this is his best song. And I saw him really shed a tear and say, thank you. Thank you. And I took that to them, and they were so happy. And they felt so happy that they had given care to their colleague. I will particularly stress on the prayer as a critical component of our care. Words, again, have effects from this side of the world where I live. Words can curse, words can bless, and so they are really valued very much. And especially words that are uttered by religious and spiritual leaders. And therefore, this includes the prayers. And I'm going to share a particular patient whom I didn't interact with it directly, but through phone.
Excuse me, Father John, just a reminder that we have a minute to go.
Okay,
so
thank you
very much.
This patient who was admitted for 3 months was also pregnant. And she told the father, I want a priest to pray for me. But I was far away from where she was admitted. And she witnessed many people die. When I prayed with her, actually, and she wanted me to pray the next day, at the end of it, she said, thank you. And after she was discharged, she got the baby, and I went back to the family to pray with them and celebrate Mass. Because she was a Catholic, I had a church service with her, and she said, when you prayed with me, I felt the responsibility of being a mother as a call from God. Thank you very much.
Thank you so much, Father John, from your experience, sharing from your experience as well. This brings us now to the second part, the last part of our session today. And we've been gathering audience questions. So we'll start with the first question. And just a reminder, you can continue to ask questions using the Q&A button in the bottom right corner of your Zoom window. If you click there, you can ask any question, and we'll try to answer them here. And also, if you want to just respond to a question, follow up with something, that is totally okay as well. So I hope we can get some discussion going. So I'll start with the first question. This question is asking, the number of people who follow alternative, non-institutionalized religions is growing rapidly in many countries. Their personal beliefs and worldviews can be very eclectic and individual. So how, as a chaplain with a specific religious background, did you engage with such patients during the pandemic? And I guess this is particularly directed to people working as chaplains themselves, but Wendy and Austyn, please feel free to speak to this as well.
I guess I've heard.
Sorry, Austyn, did you want to say something? Oh, Father John?
Please go ahead. Go ahead.
Fabian, for my sake, could you just summarize that question? Because I don't have it in front of me, and I've got to think hard about what you said. Is that all right?
I'll repeat the question. So the question is, very briefly, there are a lot of people who follow alternative spiritualities, non-institutional religions. This number of these people is growing very rapidly in many countries. You know, they have very subjective beliefs and worldviews, which are, very, very different, maybe from the big religions. So how can you, as a chaplain with a specific religious background, engage with such people, if you meet them in a hospital setting, and how did you do that during the pandemic?
Okay. if I may share, with ourselves, we are trained to be able to give religious care from our own personal religious background, all the stuff that we know about, but we're also trained in pastoral care, and we're trained to be with people and respect people for what they believe or don't believe in, or what their belief is, even if it's different from ours. And certainly within my own particular experiences, I often say to people, when I meet another patient or family or member of staff, I never wear my religious hat. I'm there as one human to another human. And it's all about accepting and understanding that every person has their own spirit. And I'm there to be led by that person. Our work is patient or client led, and it's all about them, and it's about what they want to share. And I'm there on the other end to sit, to listen, to be a sounding board if that's what they're wanting. And also for people to know and understand that not only do we give them this confidential space in which they can speak to us about anything that they want to speak to us about, but that we don't proselytize, that we are not judgmental, and that they can share what they want to be able to share. And if there is somebody that we may have from our team, or we can find from the community that comes from their particular worldview position in their belief, that we will try to be able to get that person on board as well, to be able to make that referral so they've got somebody of their own.
Thank you, Rehanah. Father John, do you have something as well on this one?
Just want to add, actually, as Austyn made a nice definition about meaning, purpose, and relationships, for me, it's actually each person, as I meet them as a human being, as a fellow human being, is what meanings are they having in their situation, and how is it helping or not helping them, and how they see the purpose and relationships. I work with what their side of the story is and not mine. I think that helps me to connect with people no matter where they come from.
Thank you, Father John. So we'll move on to the next question. This is from Gabriel Andelikwo. Do you have some experiences of how the chaplain can be effective where there are restrictions of religion and sometimes overt hostility to church? So again, I think all of our panelists can speak to this. Maybe we can start with Austyn and Wendy, who have a kind of a bird's eye view through their work. Would you like to begin?
Austyn, you need to mute.
God, I'd hate to be the first person to do that. I was just going to say to Wendy to go first, but I didn't unmute myself. Wendy, I'll leave myself up.
Yeah, no, it's a great question. And I think it, of course, depends on where you are and what those restrictions are, if they're formal restrictions or informal restrictions, and if your presence is required or optional. What I've seen in the States is that most chaplains, almost all chaplains, do work around death. They help people have what we sometimes call peripheral vision, sort of to pick up from the current situation or challenge and think and see more broadly, and to accompany. And my hunch is that in places where there are religious restrictions, that work can be done through other frames. Because for many people, perhaps for most, it's not explicitly religious work. The issues of meaning and purpose and challenge come in many different packages or frames. And so my sense is that the best way to work around religious restrictions is to try to come at the questions and the challenges from a broader, more humanitarian, more human-centered approach, as Rehanah had suggested. Austyn?
Thanks, Wendy, and I agree with all of that. And what the chaplains had said before, Father John and Rehanah, you could see that the answer to the previous question wasn't about proselytizing or religion. It's about making a connection with the individual person. And I would be absolutely delighted to be seen by either of them, because I know that they would listen to me as a human being. So in a way, I'm ducking the question here. I'm not a religious person myself at all, but I know a chaplain really helped me when my mum died 10 years ago. So, do you know what I mean? I think that we can conflate chaplaincy with religion at our peril. I've spent my research career trying to, measure the impact of healthcare chaplaincy in a fairly secular society. And it might be relevant to know that chaplains are just effective for people of no religion as they are of people of faith. And so I know that doesn't answer Gabriel's direct question about religious restriction, but I wonder if we should be looking at chaplaincy more widely than just from a religious perspective.
Can I just say something?
Yes, please.
Just to say that in a lot of my cases where I've been with people who are clear about their about their atheism, and they're very open about it and they speak about it, depending on what state or situation they're in, could be end of life, it could be a time where they've been given some really bad news and they want to now ask questions that they've never asked before. It's then when the patients themselves are actually asking very many of those questions and asking me, even though I'm a Muslim and it's clear to them I'm a Muslim, well, what do you believe, Rehanah? And that then comes to that point where I am now talking about my religion, and I'm talking about it to somebody who doesn't even believe in any religion, but that's because that's what they want. And at the end of it, when religion does come into it, I think what the authorities need to be able to understand is that it is patient-led, and it is about them, and it's about what they want.
Thank you, Rehanah. So we have a few more minutes left here, so I'll move on to the next question from Christopher. So Christopher is asking, generally, how do medical staff and hospital administration staff regard chaplains who work in the hospitals? So again, I think all of us can speak to this in some way, so as you wish.
Shall I go again, Father John, or, oh.
Yes, please.
You have to stop me. I found it amazing when I first started because we didn't have Muslim chaplains on board when I first started, and it was purely Christian. So all the medical staff and nursing and everybody else, they knew what the chaplain was, the Christian chaplain. And it was very odd for them to suddenly understand where this person fitted in, who wasn't Christian, or what a multi-faith chaplaincy department might look like. I was asked what I wanted to be called. Did I want to be called a spiritual care advisor? Did I want to be called what it was? And I actually chose at that time to be called a Muslim chaplain, simply because, even though I thought there was some, the connotations were Christian, I still felt that at least the staff would understand what I was there for. Now, not everybody still knows what a chaplain is for, but they have some understanding. And one of the things that they all do connect us with is death. And I remember my manager, God rest his soul, Reverend Stephen Barton, he was amazing, an amazing man. He said to me on my first day at work, Rehanah, chaplaincy isn't all about doom and gloom. It is about celebration. It is about the birth of celebrating a new life, etc. And those are things that we constantly try to help our staff to understand and know. So chaplains need to be really, really proactive, and we need to find ways in which to send out that message, whether it's however which way, to be able to allow our staff to know. So many of the staff now, consultants, etc., just call up because they think, the chaplain will know the answer to this. What do I do with this amputated foot for a Muslim, or whatever it might be? So it's about really understanding and getting to know and being present along with the staff. Our experiences in all the hospitals I've worked in Birmingham have been excellent experiences, but it's working hard and in trying to establish that rapport and that understanding of what we are there and what we are able to give.
Thank you, Rehanah. Thank you. Anyone else in our panel who has experience of how medical professionals see chaplains in the hospital context?
I might say briefly that I think in some settings, they see them very differently post-COVID than pre-COVID, because the chaplains were called on to do so many more and so many different things. And because in some settings, not all, they stayed and were doing so much more staff support than they were able to do before. So I think one of the longer term questions is to ask whether or how the pandemic changed how staff think about, come to, refer to, engage with chaplains, both personally in their own experience, as well as they care for patients and families.
So I guess Bill, yeah, sorry, Austyn, go ahead.
Just can I answer it from a primary care perspective? So
sure.
I know that in Scotland we have community chaplaincy listening, whereby a medical staff refer people to see a chaplain if they think they have a spiritual need as opposed to a physical or a mental health need. And those GPs who have community chaplaincy listening in their surgeries are extremely favorable of it, because, you know, chaplains help with some of the most difficult to treat people. And it also helps them, you know, where they would prefer not to prescribe an antidepressant for something spiritual, they've now got a resource to go ahead and deal with that. And so they, in that sense, and I think in general, where medics and physicians recognize the value of healthcare chaplains, they're all very favorable towards them. It's a matter of having that positive experience in the first place, I think. And that's what we noticed from the survey as well. So that's the Scottish.
Could I just mention something here? I think one of the obstacles or that we face is this misconception that the chaplain is only about religion, but not just about that, but that they may proselytize or that they will push religion on that patient. And for all of these years, I would have loved to have thought to think that this was now gone, but it hasn't all gone. It hasn't gone. And as soon as you get new people coming in to the trust where they haven't had experience with chaplains, sometimes this misconception does exist. And so we have to be continuously aware that this exists.
Father John, would you like to speak as well to this question?
Thank you, Fabian. From our experience from this area, actually, pre-COVID, chaplaincy was not very, very appreciated, to be honest with you. Very few healthcare systems appreciated chaplains and therefore hired chaplains into their treatment plans. As of during COVID, I see an increased request for chaplaincy services. Even some of the hospitals here, they have hired extra chaplains, some of them particularly to take care of the COVID patients. And this has given us an opportunity really for the staff to understand what the chaplains do with the patients. As Rehanah said correctly, that there was a misconception that chaplains are equal to religious people, servants, but it is more than religious service. But I see now a more understanding, because we are called, especially during debriefs after death. Now I see more and more medical people inviting chaplains in their context. I'm seeing a little bit more understanding and a desire to know what chaplains do now.
Thank you. So I guess going back to this point, that it seems to have been some kind of shift in attitudes towards spiritual care providers during and after, in some cases, the pandemic. So we have a question here which speaks to that. It goes, how as a chaplain do you deal with people who have strong religious beliefs against certain COVID-19 related health measures? do you see it as your responsibility to challenge people and change their mind, or are you an advocate for their beliefs? So again, this question, I think all of you has an angle on it.
So again, certainly, I've come across, and I'd still come across this in the different communities, and there has been a lot of resistance. And for me, a lot of the time when I've spent time listening to the community and to patients, etc., and families, I will allow them first to know that they've been heard. I don't advocate or negate it in any way. I have my own beliefs, my own thoughts about everything, and yes, I'm double jabbed, etc. But for me, it's all about helping those persons to understand what some of the real facts are. I was shocked that there was so much information out there at the beginning, particularly in different languages, and yet people still had misconceptions. It was almost like you had one little bit of a superstition or a little bit of a Chinese whisper that went through, and everybody's saying, oh, it's a conspiracy. Oh, you shouldn't do this. Oh, we're all being brainwashed. And lots of these things that they would then share had to be heard. And then after that, trying to help them to see what was going on, which is what chaplains do all the time, was the way that I felt as a chaplain I needed to work, allowing them to come to their own conclusion without any kind of coercion, but having perhaps a deeper understanding and perhaps being able to hear different sides in a way that they didn't hear before. And I have to admit, when they ask you personally about whether you're going to have the injection or what your beliefs are, and being a particular person of a religious standing, it does make them stop and think, well, maybe there's some truth in what I hear now. And maybe those other things were old wives' tales, or perhaps they're not true. I hope that makes a little bit of sense, but it's still being that middle person there, being with those who need you without really pushing any opinions on others.
Thank you, Rehanah. So we're now coming to a close already of our hour, but I still like to give every panelist a chance to respond to this question briefly, and then I will briefly sum it up, and this will bring us then to the end. So please, any panelist, if you want to respond to this COVID-19 question.
Am I allowed to answer a different question, Fabian? Slightly different. I'm just thinking, when people hold strong ideas about anything, I don't think arguing with them is a very effective solution. I'm talking particularly as a professor of mental health. You know, when I teach medicine management to my students, you know, we come across people who believe in homeopathy or don't believe in medicines at all. And there's absolutely no point in telling them that they're wrong, that their beliefs are not worth listening to. It just doesn't work. So I just support everything Rehanah just said. You know, that is the way to treat, you know, we will have to bring you into the course, Rehanah, and let you teach some mental health nurses how to prescribe medicines as well. That's the most important thing, is to listen. There's no point in prescribing something if someone's not going to take it, is there? Right. So we have to listen to people.
Right. Thank you, Austyn.
Then they might listen to us.
Father John, Wendy?
I'll say I agree with what Rehanah said. Actually, there were such situations here in Kenya where people were really against, and even they didn't believe that there's something like COVID. They said those are conspiracies. And especially in the uptake of vaccines. But the fortunate parts here, I could say, religious leaders, as chaplains are seen in some aspect, they are quite respected, and they get quite listened to. And when they speak, the people seem to take as being honest. But as a chaplain, I really listen to this person and here I'll do some referrals for the clarity that he has if I think there's something not very clear for him or her.
Thank you, Father John. Wendy, very briefly.
The only thing I would add is that part of the beauty of what chaplains do is they come alongside people. And as they are alongside, they're able to have a different kind of conversation sometimes that isn't about what to do or black or white. It's about building a relationship that makes a range of different kinds of decisions and conversations and possibilities a possibility. And sometimes that changes things.
Great. So yeah, this brings us really to the end. I'd like to take a minute to just highlight some of the things that have been said. Just before I do that, just a heads up that we've been taking note of all the questions which have been asked through the Q&A function. And we have taken note of these and we'll be carrying on this conversation. So all your questions have been heard, and I hope there will be future occasions to speak to them. Now, from my side, I think there's a few points which have stood out for me. One is the complexity of the notion spiritual, right? So this is not just about quote unquote religious people and their rituals and beliefs, so to speak. But there are many different ways that people connect with meaning, with purpose, with transcendence. And when they're in situations like COVID-19, these are very important resources for them, which motivate their behavior. So this is something I've heard, I think, from all of you, that it's not as simple as speaking about the clergyman, right, who conducts religious services and is called in when someone dies. So I think that this is a common denominator which we've been hearing. The other part as well is how the position is of a chaplain in a healthcare setting. So we've heard from some of you here that there's quite actually a surprising amount of recognition in some institutions and integration into the interdisciplinary care team. And then in other cases, there is a misunderstanding as well, right? And I think we need to have more data, particularly about the global South, to learn more about just how chaplains are used and what role they fulfill there. And so another thing is that, which I heard, is that there seems to be confusion as well, just and a certain invisibility as well of what chaplains do. But with COVID, this is their work has been brought to public attention as well through the media. And I think there might be a shift of attitudes. We have to look into that. But certainly there seems to be a consensus that it's not about proselytizing. And I think particularly the point of death and burial. So Father John shared as well before this session about his experience with death and burial. And of course, we know from Ebola in West Africa just how important personal beliefs are with regards to dignified burial. And WHO has worked on this, in fact, in the past as well. So the last point, I think, is very beautifully said. Chaplaincy seems to be about listening to people, and then they listen to us. Yeah. So it's not about telling people to do certain things, to change their behavior, but to listen to people, and then they listen to us. So it generates trust, it generates respect. And I at least hope that we've been able to contribute to that in some ways with this conference as well. So I hope that this panel has helped clarify some of the most pressing issues. There are many more questions we have, but the most pressing issues I think we've had a chance to discuss, and we will build on these insights to better equip our healthcare systems for the future. So this brings us to the end of the first panel of this conference. I hope this was a valuable experience for you all. Thank you so much for tuning in from all over the world. We've had a big interest, well over 100 people tuning in. There will be many more watching the recordings later. So it's been an honor to do this with you all. And we'll now take a break, half-an-hour break, and return to our second panel on palliative care during COVID-19. So thank you all very much for your participation and see you there.
Thank you. Bye.
Thank you. We go take tea and then we come back for palliative care.
Hi, Raj. How are you doing? I can see you smiling, but I think you are muted.
No, I was looking at another window. I'm sorry. How are you, Mary?
Good, good. And yourself?
Good, good, very good. We are awaiting another flood, but so far okay. Mary, the first session went well.
Yes, very well. It was focused on chaplaincy, and I think it's good to have now this specific context of palliative care. So thank you again for being with us. I think our colleagues will join shortly.
Privilege, I am sure. Thank you. So, Mary,
good morning, Dr. Raj.
Hi, Sally. Hi.
How are you?
Good morning to you. I'm good.
Good morning.
So, Sally and Mary, now that we are waiting for the others, what I propose to do in my 7 minutes is that I'll start without the slides for the first 3 minutes. Then I'll have just 4 slides to show, and I'll wind up positively by at the end of the 7 minutes. I hope I will be able to share a screen myself.
Okay, good.
What we found, I think Sarah will be back in a second, Dr. Raj.
Sure, no problem.
Charlotte, we just had the previous session, and I think one of the presenters, you have to use the full screen setting if you want to show slides, and then you can't see what's coming next.
Okay.
So Sarah can show your slides if you wanted to see the sort of bar down the side with all the next ones coming. So some people prefer that, so it's up to you.
Okay.
And when all the presenters are online, what I didn't think of before the previous session was gathering people's Twitters and also gathering quotes for Twitter. So what I am doing is gathering quotes we'll share back with you afterwards. And then if you Twitter, if you'd like to use one or just adapt it and tweet it, then share your tweet feed with us. We can then tweet it. So I'm just capturing the nice quotes.
There it is. That's mine. And I've already been tweeting about the meet.
Excellent, excellent.
Sorry, this is Alex here. Just to be aware, we're still live streamed and all the attendees are still with us. So
okay, sure. Thanks, Alex.
Thought we'd stopped recording.
A very warm welcome to everybody who's joined us afresh for this session, or who has stayed with us from the previous session. We will be starting in a couple of minutes, so thank you very much for your patience. Welcome, everybody. It's really a pleasure to have you back with us today. If you're joining us new, thank you so much for taking the time to join us. This is the second session of the WHO Religions for Peace Global Conference on strengthening national responses to health emergencies. Delighted to have you with us today on this session that is looking at palliative care during COVID-19. We have with us a wonderful group of panelist discussants, as well as two moderators that I would be delighted to introduce shortly. Before we introduce the moderators, I would like to thank our co-host, Religions for Peace, for the wonderful collaboration and partnership that we have experienced while we embarked on this project together. And I'd like to hand over to Deepika for a couple of remarks of welcome. So Deepika, over to you.
Thank you so much, Sarah. Warm greetings to all, particularly to those who have just joined us and those who have been with us since the first session. As Sarah said, I am Deepika Singh. I am the Associate Secretary General and the Director of Programs at Religions for Peace, which is the largest worldwide movement of diverse religious institutions, faith leaders and communities that has been working in the areas of peace and security, human rights, and sustainable development for over 50 years. Religious and faith leaders have been on the front line in responding to COVID-19 crisis, raising awareness about precautionary and preventive measures, combating discrimination and stigma, providing spiritual and psychosocial support, and basically serving the needs of the most vulnerable individuals and communities. So now more than ever, we do need religious and faith leaders to work together and to collaborate with other sectors of society. I think at no other time have we seen such a greater need for spiritual care as during this pandemic. The very nature of the disease with its accompanying isolation and loneliness calls for it. The pandemic has also highlighted not only the critical importance of palliative care, but the need to better integrate spiritual care and support within it. So Religions for Peace is really pleased and honored to be co-organizing this conference and this session in particular with WHO. Welcome to all and thank you for joining us. But before we start our discussion and deliberation, please join me in observing a moment of silence for all the lives that have been lost and for all those who have been and are still continuing to be affected by COVID-19. So a moment of silence, please. Thank you.
Thank you very much, Deepika, for those words. I would now like to introduce our two moderators for the session. We have with us today Marie-Charlotte Bousseau, who is the team lead here at WHO for Integrated Health Services. So Marie-Charlotte, thank you so much for joining us. Our second moderator is Father Rick Bauer, who is a Roman Catholic missioner and I think is based actually at the moment in Nairobi. So welcome, Father Rick and Marie-Charlotte. Over to you for the moderation of the session.
Thank you so much, Sarah, and thank you, Deepika, for this introduction. It's actually a great honor for us to be part of this session because we have been working from WHO on palliative care for quite a long time now. Having in mind that spiritual care is definitely part of this work, but I think it's sometimes not always addressed as it should be. So this session is really an excellent opportunity. We also have the privilege to have excellent panelists. I would pass on to my co-chair now, who is Rick, and then I would invite you to watch the WHO video we launched on the occasion of the World Hospice and Palliative Care Day this year, just to introduce our discussion. So Rick, over to you.
Great, Marie-Charlotte, thank you so much. And it's an honor to be here. And yes, I am in Kenya right now. And I'm a board certified chaplain in palliative care. And so it's great to be here. So without any further ado, let's begin with the video.
Marie-Charlotte, I'm sorry, just give me a minute. I'm just trying to get it up and running. Alex, may I ask if you are able to, for some reason my screen has frozen.
Yes, one sec. Okay.
Great, and thank you so much. It is now my privilege, my honor to introduce my colleague and my friend, Dr. Emmanuel Uyirika. Dr. Emmanuel is the Executive Director of the African Palliative Care Association, a Pan-African palliative care program with programs in over 24 African countries. He's a board member of the Worldwide Hospice and Palliative Care Alliance, the president of the executive board of Korsu Hospital in Uganda, a charitable rehabilitation and plastic surgery service for children and adults with disability. He's a strong and a passionate advocate for palliative care throughout the world, but especially Africa, and always lets me talk about how important spiritual care is. So I welcome Dr. Emmanuel.
Thank you very much, Father Rick, and thank you for the opportunity to be on this panel. It's very important for us to talk about palliative care and spiritual care in particular. It's important for us to note that spiritual care needs exist right from prevention, at the time of diagnosis, at the time of treatment, at the time of rehabilitation, and at the time of provision of palliative care, and when the families are going through grief. However, the spiritual needs tend to be bigger around the time when patients need palliative care. And that calls for us as clinicians to think beyond the biomedical model that taught us about disease and think wider about the things, including spiritual care, that makes patients suffer, even in the presence of other professionals. I want to look at about 7 things that clinicians and people in clinical settings where they provide palliative care need to think about. First of all is to unlearn the things that we've learned in the past, because there are many things we've learned about spiritual care, about care in general, which as providers of services need to unlearn, so that we are not judgmental, so that we are able to listen to patients and their families better, so that we are able to make comprehensive assessments, plan for the needs of those patients, and then take action. Secondly, that would be isolated unless we used the existing global and regional frameworks that talk about spiritual needs of patients and domesticated them in countries and even within our protocols as countries and programs that offer palliative care. It's therefore important for us to domesticate those frameworks and make sure that our protocols, our guidelines include palliative spiritual care in palliative care, so that we can properly address the needs of patients. COVID has taught us many things where patients have been isolated, family members have been isolated, and others left without any support that they need. And spiritual care has been more needed at that time. And therefore the need for providers of palliative care to create room for their clinicians, for other chaplains to work together with them to provide spiritual care in that context. We also need to develop and systematically implement curricula, whether pre-service or in-service, that enable providers of palliative care to get the skills that they need to do the proper assessment and manage the spiritual needs of patients, but also refer patients to those who are more qualified to meet the specific needs of those patients. We therefore need to invest in best practices and research that feed into the palliative care programs to be able to use evidence-based best practices and models that actually meet the needs of patients. Spiritual care should be seen as part of the entire package that we provide to patients. And the package that we have developed for Africa that was shared with the ministers at the last conference has spiritual care as part of that package. We need to also modify the data collection tools at the points where we provide services. Within our palliative care programs, we need to modify our patient data collection tools so that we can capture the spiritual information, the spiritual needs, and the challenges, and therefore respond appropriately. We also need to expand the reach of chaplains and work with them within our facilities, so that patients are not left to suffer when they have spiritual distress. Within our clinical practices, we need to have proper referral systems for the spiritual needs and challenges that we cannot meet as professionals, so that we do not leave patients hanging with the spiritual distress that they face. We need to capture the feedback from patients. And I think that is so critical, to routinely capture the feedback of patients, even as we have our weekly meetings where we are reviewing what has happened over the last week, to be able to capture the spiritual needs, the spiritual challenges, how we've been able to meet them or how we've failed to meet them, so that we can appropriately plan for the patients. But above all things, palliative care programs need to allocate appropriate resources within their practices to address the spiritual needs of patients, either through equipping the providers, the multidisciplinary teams that we have within those hospices or hospitals or community-rich programs. We need to ensure that we have links and networks with people who have the expertise in spiritual care to train and re-equip our teams, but also to be able to take spiritual care as part of the entire package, so that it's not just seen as an additional prayer with the patient, but as part of a needed comprehensive aspect of care for which patients always yearn. And finally, it's about creation of awareness at the practitioner level within the clinic or the palliative care unit, awareness at the policy maker level, so that they can also create room, space, and resources for integration of spiritual care into our palliative care programs, to create awareness among the patients and their families that they can feel free to express their spiritual distress when they are in the midst of palliative care programs. Thank you very much, Father Rick, and everybody else for listening to me.
Thank you so much, Emmanuel, for this very concrete and stimulating reflection on spiritual needs in palliative care. It's now my pleasure to introduce Dr. Raja Gopal, and I know that you prefer to be introduced as Raj, so I will call you Raj. We actually know each other for a long time. You have been one of the pioneers of palliative care in your country, India, in particular in Kerala. And I wanted to ask you, what has been your experience of providing spiritual care within palliative care in the context of this COVID-19 crisis, which is still ongoing? What would be the lessons we could learn regarding ways to address these needs, these complex needs for the patients and their families, in particular for home-based palliative care? So over to you, Raj. You have 7 minutes.
Thank you, Mary. And namaste, everybody. Namaste means that I bow to the divine in you. I come from Kerala, as Mary said, where it's a multi-religious community, about half of Hindus and a quarter each of Christians and Muslims, with a splattering of other religions. I also belong, like Emmanuel, to 83% of the world, the low and middle income world, for most of which, please remember, we do not have specialist spiritual counselors. We do not have chaplains. We are talking about 83% of the world. And here, I'll try to explain what we do. Let me bring up the story of a man, this man who came in screaming and thrashing about with cancer pain. And his wife actually pulled me aside and said, please kill him. I cannot bear to see this anymore. He has been like this for 3 weeks. A well-meaning volunteer went to him and said, pray, pray, I'll pray with you. The man rudely pushed him away. We instituted our protocol for management of a pain crisis with small aliquots of intravenous fentanyl going into his veins. In about half an hour, he had substantial pain relief. The next day, I saw him eating breakfast. He said, you people have worked this magic. Can you also cure me? It took 2 or 3 days for him to come to acceptance of incurability. And one day, I sat down with him and said, tell me the story of your life. Well, he needed some persuasion and eventually it came out and then it wouldn't stop. He told me how he grew up in poverty, how he made himself a self-made man, how he built his family and brought up his children as decent people. And at the end of the story, I said how much I admired him for his integrity, his hard work, and his rule that work is worship. Why am I recounting the story? In the absence of spiritual counselors, palliative care for us is every palliative care provider's business. It is the work of volunteers, nurses, doctors, pharmacists, everyone. I would summarize spiritual care as something that many centuries back Paracelsus said. It's about love. There is no chapter in any textbook of medicine on love. But that is the essence of medicine, and it was at that time, and it is now, I strongly believe. This is Dr. Chris Booth, an oncologist from Canada, who, when visiting us, joined us on home visits. He had a question to one of the patients. He asked a man, what does the visit by the home care team mean to you? And here's Chris published this in the Journal of Global Oncology. And this is how the man said, first of all, I feel very loved. Spiritual care, ladies and gentlemen. For us, spiritual care is about listening to their stories, conveying that we care, finding out what the person is. I do not mean whether he's a farmer or an official. I mean what makes up the man's heart and soul. What values does he hold dear to him? We find out what meaning life holds for him. That helps us to find a purpose in his life, whether it's only for 2 days or for many years. Achievable, realistic hopes are nurtured and supported. We find out what connects them to the world. For a lot of people, the connection is to God or religion. And if somebody wants to meet a priest, we facilitate that any point of time. But everyone tries to keep the person connected with love. This man actually wanted to, the man who came in pain, wanted to go to his primary school. He persuaded his sons to take him. He had only primary education. He walked around there on a Sunday and moaned about the state of things now. And on his way back, he told his son, I am at peace now. He wanted to meet his brother with whom he had quarreled many years back over some dispute. He came, they cried together, they hugged and cried together. And those connections are important. It may not be with God. For many people it is. If not, it may be with the environment, the tree outside their own personal window. It could be the nature, anything. And our effort is to rebuild that connection. These would be the steps of what we do. Most importantly, convey care and love. And today, in the midst of the pandemic, this is particularly hard. We all wear face shields and armors. We have to do a lot of this with our voice and when possible with our eyes. This, I think, is the most important part of spiritual care. Convey that the person matters. We care for you. We have love for you. We try to listen to their stories and get to know the person as he or she is. We acknowledge the positives in their stories, the value of their lives. And I would hope we would like the person to feel that my life was well lived. We find out what is meaningful for that person. We build a purpose into the life for the remainder of time, and we try to rebuild connections. This, ladies and gentlemen, is palliative care for us, which was always important, and now in the face of the pandemic, so vitally important, especially for the families left behind in pathological grief and who need support. Thank you very much.
Thank you, Raj, and thank you for bringing the patient in this conversation and insisting on the fact that spiritual care is actually a shared responsibility for all palliative care providers. I would like now to turn on to Hiba Osman. Hiba is the founder of Balsam in Lebanon, which is a Lebanese Center for Palliative Care. She's currently working in Dana-Farber Cancer Institute in the US, and I think this double experience is extremely important for our discussion today. I would like to ask you, Hiba, based on your experience of very different contexts in Lebanon, including in refugee camps in Lebanon and in the US, how would you describe the integration of spiritual care into palliative care, and especially in the current COVID-19 crisis? What kind of specific needs are actually raised? What would be the lessons we can learn, maybe especially as Raj was just mentioning in settings where there is no chaplaincy? So over to you, Hiba, and thank you very much for being with us today.
Thank you for the introduction, Marie-Charlotte, and it's a pleasure to be with you today. I think the question you raise about the contrast and being here, I'm with a team. We have a wonderful chaplain on the team. I work in a context where chaplains are trained to deal with people with different religious backgrounds. But to contrast that with Lebanon, which is less familiar to, I'm sure, most people on this in this workshop, spirituality and religion are very important to most people in Lebanon. But unfortunately, we've had many years of war and conflict that have been along sectarian or religious lines, and Lebanon and the region, which makes religion and the spiritual dimension actually really politically charged. So the team I work with in Lebanon is a home-based palliative care team. We have nurses, we have physicians, we have social workers and a psychologist, and we work together to provide care to patients of different religious backgrounds, and the team itself is actually of different religious backgrounds. Because we don't have chaplaincy in the team, and it's not because we haven't tried to find chaplaincy, but for one thing, there isn't that course of study in Lebanon, and it's not a profession that really exists. So we didn't have that option, unlike the options that I have here. So really, it's the doctors and nurses and social workers who try to address the spiritual issues and do the spiritual assessment. There's a spiritual assessment tool called the FICA, and it's actually, it assesses the spiritual dimension for patients along 4 dimensions, and Raj alluded to that. It's asking patients if they consider themselves spiritual or religious, if faith plays an important role in their life, if they're part of a religious or spiritual community. But you can imagine these simple questions to understand a patient's spirituality and the role it plays in their lives in a setting like Lebanon can be very politically charged. And so even though we have the FICA tool in our initial assessment, so the nurse is supposed to ask these questions on the first visit, I can tell you almost universally, it does not happen on the first visit, because we feel that it can make patients feel like we have an ulterior motive. We're asking them these questions to actually determine their political affiliation rather than their spiritual beliefs. And that might impact the kind of care they receive if they're of a political affiliation that doesn't resonate with the nurse or the doctor taking care of them. And you can imagine in the refugee community how much more politically charged that question might be. So asking these questions becomes a very different issue in a context like ours. So usually we reserve these questions to later after we've built trust and developed a relationship with patients. But yes, we do that as a team. So we have doctors, nurses, and social workers addressing these questions, trying to address the existential issues and distress that patients might have with the minimal superficial level training that we have. And I can tell you, I've been doing this for over 10 years. The way I did it 10 years ago is very different to the way I do it now. So I think what I would ask for and push for in this context is the importance of cross-training other members of the multidisciplinary team in settings where there are no chaplains to do a much better job of addressing spiritual and existential distress. Because the training that we have is not enough to meet these needs. Another issue that I would like to discuss is also the relationship of the medical community with the religious community in contexts that are very, in settings where people are very religious or spiritual. The religious leaders play a very important role in medical decision-making for patients and families as patients get sicker. So they go, very often our patients will go back to their religious references when we're discussing goals of care, for instance, things like resuscitation and intubation and admission to the ICU in a seriously ill patient. That medical decision-making for a family involves understanding what their religious guides would tell them about what the right decision to make is. And very often, the medical recommendations and the religious recommendations might not resonate. And in the setting of COVID, you can imagine how that could have been really challenging when we had limited access to equipment such as ventilator support, and medical decision-making involved some kind of rationing of care and use of such equipment for people who were more likely to survive than not. When the religious guidance involved doing everything no matter what, etc. I don't know if it's been mentioned before, but there was an initiative from a group of palliative care providers with the Vatican, and they wrote a white paper on with the Pontifical Academy for Life in 2018 with Carlos Centeno and a team of palliative care providers from different religious backgrounds. And I think this would be a very important step to do across different religions from the palliative care global community rather than in countries and contexts, different contexts, to come up with recommendations that would be applicable to the different major religions as it relates to palliative care and that are in line with religious teachings. So those are the main points I would like to make. I think teaching medical teams to provide the spiritual support necessary in settings when there are no chaplains, and to train them with sensitivity to the context would be important. And then working with the religious community to try and provide recommendations about end-of-life care and seriously ill patients. Thank you.
Thank you so much, Iba, and thank you for pointing this tensions that can appear in some context where the political situation makes things even more difficult. I will now turn on to Rick for the introduction of our last panelist. Rick, over to you.
Great, and thank you so much. And thank you so much, Dr. Osman, great presentation. I love challenges. So when I hear them, it's like, how do we address this? We can do this. It is also my pleasure to introduce my colleague and my friend, Dr. John Twee. He's a Roman Catholic priest with the Chameleon Fathers and Brothers. He is a physician's assistant, has a diploma in public health, completed a licentiate in Rome in clinical psychology. For many years, he was in charge of the Pastoral Commission for People with AIDS in the Saigon Archdiocese. He organized a group of interreligious congregation to provide end-of-life care for those dying from complications with HIV. And he founded a shelter for children living with HIV and a hospice for the homeless with HIV. Of course, now much of his attention has been addressed to the COVID pandemic. So, Father John, I understand you're in the midst of overwhelming needs on a daily basis. And so can you speak to something of your current experience providing spiritual care? But I also want to make sure we mention children and the importance of providing spiritual care, not only for adult palliative care patients, but also pediatric patients. Thank you so much, Father John.
Thank you, Father Rick, for your introduction. Allow me to share some slides also, if it's possible. Yeah. Okay. So I try to get the background of our topic today, and thank you so much for your invitation for this conference, and I feel very much honored. Let me share with you some of the context that I'm in now. I'm working in the intensive care unit for COVID patients, those who are in intubation or who need emergency care and to help them to recover. But many of them are dying as well because of the complication. So I was invited by the Medical University Hospital to assist the patients in psycho-spiritual support, and also the staff in the place. And because of having the medical background, I also assist in caregiving for the patients in the COVID intensive unit. So what happened to the patient with COVID in Vietnam? First of all, as many other patients being isolation, they were cut off from their family, they were put in isolation, and they were not able to keep in touch with their family. And before that, there was a kind of a trace contact as well. Whoever they have met before, the health officers and other government officers would trace those contacts and put those people whom they met in isolation once they found positive with COVID. And then many of them dying without a chance to meet their family, loved ones, and without an opportunity to even meet their spiritual leaders. And other consequence is no funeral right. In Vietnam, I believe in most of the country in Asia, the last right, the funeral right, whichever denomination that person belong, is very important, where the family can gather to share memorial service and also to make sure that they see their loved one, they send their loved one. And this right cut off because of this COVID pandemic. And then a loss and unrecognized grief because of the pain and the grief that they have. They lost a loved one, and then also the loved one lost them, but were not able to live their grief or to be recognized, the right to live the grieving moment. And also stigma and discrimination. I met many patients when they were discharged. A few days ago, I had 94 years old man was survived of COVID, and then he left the hospital, but he didn't know where to go because the family were far away in the province, and the house where he stayed, the renting home, didn't want him to come back. So that kind of stigma discrimination create a long list of consequences to our patient with COVID and the people who dying. Fear and panic, shame, thinking that I have got COVID and then I have transmitted to others, suffer loneliness. All the patients with COVID share with me, 100% of them share with me that they are very lonely. They suffer loneliness, terrible. So they long to have someone be there with them or to stay longer. And you know, very hard to find someone who can stay longer with them, of the risk and many other things many of you have known already. And the pain and fatigue and long haul COVID syndrome, many of them couldn't go home without assistance. And so with all those kind of syndrome, they have a secondary loss in kind of palliative care. We know that there is in the grief moment, we have also secondary loss. They lost a job and also they lost their health. They cannot recover their health as before. Lost family members, many of them were dispersed. One were put in isolation in one center, and the children were put in isolation in pediatric hospital. And now they couldn't find each other. It's very terrible. And orphanage in Ho Chi Minh City, we had in this recent wave of pandemic, we have 1,500 orphans because of COVID pandemic. It's terrible. And the children, they didn't know how to handle that. Yeah, many of them were so scared because before that they were put in isolation, and then they came out of isolation. Their parents were lost. Yeah, that was very painful for them. They cry all the time. Lack of proper care and being abandoned, lack of resource, depression and anger. I encounter many patients in the dying moment. They want to kill themselves. They want to suicide. They said that, is there a way for me to kill myself, to die? So I would rather die now. So a kind of loss of sense of self, because our sense of self is belonging, the purpose, the meaning in life, totally lost. And children were not able to connect with parents during sickness, and they didn't know what their loved one have died. And patients with other serious illness, non-COVID, suffer neglect as well. So those are the things. I share with you the context of where I work. This is the emergency COVID intensive care unit, where every day I come in and I receive the list of patients who need to attend to, who need spiritual care. Thanks to the openness of the administration of the hospital, they see that there's a need to provide spiritual care and counseling, and to assist the patient to improve their cooperation and to make them feel peace and calm, even if they are suffering. So they provide to me the list of the people who are suffering, especially also the list of people who the life expectancy is going very short. The prognosis is very bad. So I have that list. I go around and I help the nurse, and also I talk with the patients. I try to be there with them. So what I try to do is to keep them in touch by rebuild a sense of self, by being present with them. Stay longer than just 5 minutes, but 15, 20 minutes with them. Even sometimes they just look at me and cannot talk. Like the lady on your right, you see, she couldn't talk because of intubation. But we try to stay there, and sometimes I use the board to have an alphabet and to point to her, so that to listen to her and to let her express herself. And very often she talk about her daughter. She will worry about her daughter back home, no one taking care of. Or the lady in the left, we try to have her a video conference with their family member. So keep in touch, and we instill hope. I try to instill hope by listening to their story. Many of them have a lot of story that were not able to tell before they enter the hospital. They want to share to their family member. They want to say something important about them, about what they want from their family member to remember. And then hold on to the faith and purpose in life by allow them to talk about their God. Being a Catholic priest, but I'm not there to tell them about my God, but I let them talk about their God, even the Buddha, even Muslim. I let them talk about their faith and how they count on to their faith to be the foundation of their life, and move on with hope from there. And then in the end, I ask family member to pray and record the prayers so that the patient could listen, even when in ventilator or even in coma. Every day I put my phone on the ear so that they can listen to the prayer of their family members. Keep praying for them, hoping that they can listen. And I believe that I listen as well. Many of them turned into tear, even their eyes were closed, but tear came out of their eyes. Yeah. So we also gather nurse and staff to pray with the patients when the prognosis is very bad. We pray when they were dying. We talk to them and pray with them so that they feel that they were not being abandoned or lonely. And yes, when at the moment of death, we provide a ritual in the hospital for them, and we invite staff to participate whatever we can. And then also memorial service. So you see the staff who are who have a Buddhist belief in Buddhism. Also, we set up an altar for them to pray in memorial service, and then the family member also pray in front of their loved one, and we keep the name tag of the patients inside a circle of flowers to remember. So those are some pictures that I want to share with you, to share about the experience that I have with the patients dying with COVID, and we provide palliative care for them. And for me, the important is keeping them in touch and saying to them that they are not alone. We are there for them, and instill hope and faith despite of this kind of isolation and sickness. With the children with HIV, actually I learned this from them as well, because the children, they long to listen, to hear that their family, their loved one, be there for them. And I work with the children with AIDS. Most of them were abandoned, and I brought them back to our shelter. And some of them, despite of medicine, they die because of complication of AIDS and of late treatment or AIDS resistant. They came to us too late. And the only thing we try to do is to help them to understand that we try our best to replace their parents, although we cannot. But we are there for them, and we're not afraid to hold them and we tell them that they are important to us. So I always tell them, to the children, they are important to us. And if their parent died, I try to let them talk about the grief they have for their parents. Many children in Vietnam didn't have that opportunity. They were cut off from this participation of grieving moment. They were cut off from sharing their pain. When they cry, the parent feel that they cry, that the sound of the cry is so painful. They're trying to calm them down by different means, but not allowing them to talk about their painful experience. So this is something that lacking in our culture, as well as the way we practice. We don't want to listen to the distress of the children. So many children didn't have the time, the chance to talk about their distress. They would suppress more than allowing to talk, to cry, because the only way that children can do is crying. And we don't accept their cry. We want them to keep quiet. So for me, that is unrecognized grief and pain that many times the children have to face. Or they have to be the hope for their parent, by the parent try all means to keep them alive. But sometimes they have to be accepted that they cannot. So many times the parent keep on life sustaining despite of the problem, the illness like cancer, and they have to suffer. And we don't understand their pain at all, because they cannot communicate well, aside from crying, from being in distress. We cannot, and as adult we miss out these things a lot. So how can we bring meaning to these children, bring comfort in them, and help them to understand that their pain is our pain, and we are willing to embrace their pain. And for me, that would help a lot for in the practice of palliative care for the children, that in my experience I could share with you.
Great.
So I would like to finish my.
Thank you so much, Father John. I really appreciate that. And I really am grateful again for even our previous session under chaplaincy, is the importance of staff care, the importance of staff care in palliative care, but for all of us. There is a great question from Samuel that was kind of asking, what happens when there's divergence between the physical needs or the spiritual needs? Or I'd even expand that, in palliative care, we look at the biopsychosocial spiritual. And what happens when any one of those domains diverges? How do you reconcile those? So I put that to the panelists of what happens when there's different needs in those different domains.
May I?
Please go ahead, Raj.
Thank you very much. To me, the answer is simple. We are care providers. We can provide physical care, we can provide spiritual care. But the person has right over his or her own life. What is the greatest need is something to be decided by that person. And our task, our responsibility is to empower the person to have enough knowledge about the situation and make his choices. Autonomy is the overriding principle here. Thanks.
Thank you so much. And again, I think that is one of the huge strengths of palliative care, is that we are always talking about person-centered care, whether that's in the biological or the social or the emotional or the spiritual. It's not about my spiritual needs, it's about the patient's spiritual needs.
May I say something?
Please,
Yeah,
please.
For me, we don't weight spiritual need or psychological need or physical need. We presume that every person have those needs. But as being a spiritual caregiver, we use our own experience or our own training to be there with the patient in that moment. And if that time they need us, we respond. And if they feel that okay, I'm so tired, I need to care of my body, I need to sleep a little bit, that is the time they need more for the physical need. So we respect them. So of course we are there for them anytime. So normally we don't do assessment, but we come to the patient and let them share how they want us to care for them. Yeah, and we provide that care as much as possible we can. Yeah.
I would have a personal question to our panelists. Iba mentioned that we might want to come back to the white paper that was issued after a session organized by the Vatican with different religious tradition. And in the chat exchange, we also have seen that we should include as much as possible indigenous tradition also to this discussion. How would you see the potential collaboration with organizations such as WHO? We have heard today that it's extremely important to have a global framework, but also the possibility to domesticate this framework and to adapt to the diversity of settings. How would you see further collaboration between global initiatives and more local, national initiatives from the field? Any of our panelists maybe has some suggestion for us.
I can jump in. I think if like all WHO resources that we've had some wonderful resources that have come out in the past and also recently. People on the national or regional level use those resources as advocacy tools. So I imagine if there was something that would come out from WHO, people say in Lebanon would take it to the religious leaders and use it to start a dialogue. So when it comes from a body like the WHO, it gives people on the ground power to start a dialogue. It gives us something to jump off from. So it might need local adaptation, but it's a really great way to start.
Thank you, Iba. Other suggestions or ideas?
Mary, when you proceed with this consultation, I hope you will remember that the majority of countries may not make themselves heard. The low middle income countries' voice is heard by so few, and it will be vitally important to get many countries to chip in and formulate comments. But you specifically asked about indigenous systems of medicine. And that is so important that because so many, a good percentage of population actually access them, not modern medicine. But the catch is, if it would be wonderful to get all together around a table, if they are all people who put the patient and family at the center. Instead, if they are going to fight over my system of medicine, then we have a negative consequence on our hands.
Thank you, Raj. I think we are almost coming to the end of this session. So personally, I don't want to conclude in any way, but I think we had extremely useful food for further thoughts and also very concrete suggestion for future collaboration. So I just want to thank again our panelists and also all the people who were connected to this session and contributed with comments. I'm sure this is just one step, and we will definitely continue the journey together. Over to you, Rick, and to our organizer for this session. Thanks to everybody.
Well, and Dr. Maria, I want to thank you for always putting palliative care on the agenda of the WHO. Sometimes it slips off the side, and so we're very grateful to you for keeping palliative care on the WHO agenda. And so with that, I will turn this back to Sarah.
Thank you very much, Rick. Thank you very much, Marie-Charlotte, and also to all the wonderful presenters. I want to thank you so much for coming today and sharing your amazing stories of commitment to this area of work. And it's been a real pleasure to listen in. And I look forward to continuing the conversation. I want to say thank you also to all those who've joined us today to watch. As you all know, this is this session is part of a conference that's ongoing between now and December. So I think Alex has put in the chat the link to the webpage that you will be able to see other sessions to be able to join those. I want to just say thank you to my team as well, and all those in the back end who have supported, and our wonderful interpreters who have provided interpretation into Spanish, French, and Arabic as well today. So thank you, everybody, and we really do look forward to seeing you at subsequent events. Take care.
Thank you. Thank you very much.
Thank you.
Thank you, Sarah, and thank you, Frederick.
Thanks,
thank
everybody.
you, all of you.
Thank you. Take care.
Mary. Yeah.
Bye-bye.
Thank you, everyone.